All right, let's talk about something we all see constantly in our practice, nipple pain. We know it's a huge reason parents stop breastfeeding, but the causes, they can be so tricky to nail down. So today, we're going to take a super dense clinical chart and turn it into a practical cheat sheet, something to really sharpen your assessments. Let's get right into it.
So this is our source material, our playbook for today. This table is an amazing tool. I want you to think of it as a roadmap. It connects what you're seeing and hearing to the why behind it and then to the right intervention for every single scenario. We're just going to walk through it piece by piece so you can build this framework right into your brain.
So here's how we're going to break it all down. First up, the absolute basics, latch and positioning. From there, we'll go a little deeper into trauma and infection. Then we'll get into some of the more unusual causes you might run into. And finally, we'll pull it all together into a core toolkit. See, we're starting broad and getting more specific as we go.
Okay, let's start where you always have to start. Section 1, latch and positioning. And I mean, let's be honest, this is the root of the problem the vast majority of the time. If we can get this part right, most of the puzzle is already solved.
And that brings us to rule number 1, the golden rule, really. Before you even let your mind wander to thrush or vasospasm or anything else, you must check the basics. Is that latch deep enough? Is the positioning right? This is your starting line, every single time.
You know, one of the most important things we do is help parents figure out what's normal versus what's a real problem. That initial stretching feeling that lasts for, maybe 30 seconds, we can reassure them. That's normal. But pain that just doesn't quit, pain that lasts through the whole feed, okay, that's it. That's your big red flag that something's off with the latch or the baby's suck. So what do you do right then and there? Well, first, you coach for a deeper latch, obviously. If it's just that initial stretching, you reassure. But if that pain is sticking around, try some breast massage to get the letdown going faster. That can really help ease things. And hey, if it's really bad, there is zero shame in taking a break. Have the parent hand express and cup feed. Give those nipples a rest so you can figure things out.
Okay, let's add another layer to our diagnosis. I want you to ask yourself this question. You're not just looking anymore, now you're listening. Are you hearing any clicking, any smacking sounds? Because that's not just random noise, you guys. That's data. So why do we care about those sounds? Well, because that clicking means the baby's tongue is literally losing suction and popping off the nipple over and over again. This is more than just a bad latch. It's a huge signpost pointing to a possible oral anatomy issue, like a tongue tie, that needs a much closer look.
So what if you've done all the latch correction and the pain is still there? Where do you go next? That brings us to our second section. It's time for a deeper dive into physical trauma and possible infections. Now we're shifting from what the parent feels and what you hear to what you can actually see with your own eyes. The question is simple. Is the skin broken? Are we seeing cracks, little abrasions, basically any kind of open wound?
9 times out of 10, the reason for this is just friction. The nipple is rubbing against the baby's hard palate because the latch isn't deep enough. So the intervention here has 2 parts. First, you got to fix the cause, right? Correct that latch. But second, you have to treat the wound itself. Advise rinsing with clean water and then applying something that will keep the air out to help it heal without forming a scab.
Now, I want you to really listen for these specific words from a parent. This is a totally different kind of pain. We're not talking soreness anymore. If you hear stabbing, shooting, or radiating, your brain should immediately shift gears away from simple mechanical problems.
And here's why those words are so important. That kind of pain often follows a specific nerve path, the 4th intercostal nerve. It could be from direct trauma, like if the baby is biting down. But, and this is so crucial, it can also be a telltale sign of an underlying infection like thrush.
And here's the real giveaway for an infection. What happens between the feeds? If the nipple is still inflamed, red, and that deep stabbing pain is still there long after the baby's done eating, that's a massive red flag. That's your cue to team up with a doctor to check for a bacterial or yeast infection.
Okay, so now we're getting into the less common stuff. This is the part of the flowchart you go to when you've ruled out the usual suspects, the mechanical issues, the common infections, and you're still stumped. Let's look at some atypical causes.
This is a super specific visual cue. You need to be watching for this the second the baby unlatches. Does the tip of the nipple suddenly turn completely white? Some parents even say it looks like the end of a lipstick tube. So what is that telling you?
That is a classic textbook sign of nipple vasospasm, which is sometimes connected to Raynaud's. This has nothing to do with latch. It's a circulatory thing. The blood vessels are clamping down, causing that white look and a really intense burning pain as the blood flows back. The intervention here is totally different. It is all about warmth. Gentle, dry warmth right away can make all the difference.
And last but not least, in this category, you have to remember to zoom out. Look at the whole person. Do they have a history of any skin conditions? Because at the end of the day, the nipple is skin, and it can be affected by all the same things that affect skin anywhere else.
You might be looking at psoriasis or eczema on the areola. Maybe it's an allergic reaction to a new nipple cream or nursing pad. And you also have to consider things like ringworm or even a viral infection like herpes. This is where your role as a collaborator is so important, because all of these require a referral to a doctor or a dermatologist for a proper diagnosis.
Okay. Phew. We have made it through the entire diagnostic funnel. So now let's bring it all home and put together a really clear, practical toolkit that you can start using with your clients tomorrow.
So let's talk about what's squarely in our wheelhouse. You are the deep latch expert. You are the one who can teach massage and hand expression. You can give that evidence-based advice on wound care. And so importantly, you can empower parents just by helping them understand what they're feeling. And for pain from trauma, don't forget that over-the-counter anti-inflammatories can be a good conversation to have with their doctor.
But just as critical is knowing when it's time to bring in the rest of the team. For any suspected infection or skin condition, you're working with doctors and dermatologists. For really stubborn vasospasm, you might be part of a discussion about prescription meds. And for infections, you got to remember that other family members might need to be treated too. Honestly, knowing your scope and building that referral network, that's the sign of a true professional.
And that is our cheat sheet. So I'm going to leave you with a final thought to take with you. After all this, which one of these easily misdiagnoses, maybe the subtle clicking sound or that telltale blanching, which one are you going to be watching for just a little more closely in your next consultation? Thanks so much for joining me.